This video describes the first Tendyne transcatheter mitral valve replacement done in New York State at Southside Hospital, Northwell Health, and Bayshore, New York. The procedure is then a part of the Summit clinical trial. After a complete planning of procedure that is done by transesophageal echocardiogram and cardiac CT scan prior to the procedure, the location of the transapical axis is confirmed with the transthoracic echocardiogram in the lab. A routine transesophageal echocardiogram is performed focusing on mitral valve, evaluation of pericardial effusion, left atrium or left atrial appendage thrombus. Transgastric view shows mitral regurgitation and normal outflow tract gradients. Transesophageal view shows severe mitral regurgitation. You can see significant flow convergence at low radius and velocity, or PISA. There is dense spectral Doppler pattern, and flow reversal is seen in pulmonary veins that are just suggestive of severe mitral regurgitation. The anterior leaflet, if elongated, may be obstructing the LVOT after placement of the mitral valve, so it's measured. This is a three-dimensional en-face view showing the mitral valve in surgical view with aortic valve anteriorly at 12 o'clock position. Color Doppler shows the central jet and the flow through the aortic valve in a 3D view. The X-plane at 60 degrees or commercial view is beneficial throughout the procedure. The apical axis is confirmed at the surface of pericardium. You can see the dimpling or the indentation. The axis apex is the apex that is in the center of the mitral annulus. This may not be the true apex. In this case, the axis site is lateral and anteriorly. The indentation of the apex was clearly visualized on 2D and 3D. A needle axis is obtained, the wire is visualized in the LVOT, and then a Fogarty catheter is passed through the mitral valve to confirm the wire does not pass through the chordae. In this clip, you can see the Fogarty catheter and the wire through the mitral valve into the left atrium. In this view, you can see the sheath being introduced through the apex, making sure the wire remains in the left atrium. The sheath may cause echo artifacts, so X-plane and 3D views are always used to confirm your findings and interpretation. The sheath is also adjusted to keep in the center of the valve. 3D views may be helpful. Make sure it's not moving lateral or medial. It may indent the anterior leaflet of the mitral valve and cause severe mitral regurgitation and hemodynamic compromise, so it has to make sure that it does not indent the anterior leaflet of the mitral valve. The valve is then deployed through the sheath slowly. You can see the valve coming out of the sheath slowly. With X-plane and 3D views, the anterior cuff is confirmed. Slow deployment of the valve is done throughout the procedure. You can see that the anterior cuff is longer than the posterior cuff. In the 60-degree view or commissural view, you can see an X-plane, and the cuff should be equal in the 60-degree view. The 120-degree view should show the anterior cuff, which is longer than the posterior cuff. Slow deployment of the valve is continued, and you can see that the anterior cuff is longer than the posterior cuff and is slowly deployed over the aortic annulus. In the 120-degree or the long axis view, the longer anterior cuff is seen with a shorter posterior cuff. You can also appreciate in this 3D view the longer anterior cuff and the shorter posterior cuff and the position of the valve. In this 60-degree X-plane view, you can also see, you may be able to appreciate a bigger pockets between the outer valve cuff and the inner valve, both in medial and lateral, and the anteriorly you can see only a small cuff. Color Doppler is used to make sure that there is no significant paravalvular leak. Then a tether tension is maintained through a small string all the way to the apex, and the tether tension is then attached to the apex of the LV. During this time, it is make sure that a valve is not changing position or is not moving. During evaluation of the valve, the operators are maintaining a constant tether tension, holding the valve in place while completing the procedure. Color Doppler is used to evaluate for paravalvular regurgitation. The valve is observed to maintain the position and is not overriding the annulus into the left atrium or below into the left ventricle. Once valve position is confirmed, stability of the valve is maintained until the tether is attached to the apex. Tether tension is checked hemodynamically and visually echocardiographically. A pigtail catheter is usually used to evaluate the LVOT gradients and measure LVEDP, and the amount of tension to the LV apex is measured via a device. You can visualize the apical indentation due to the tension. This is to assure the valve does not change its position and lead to paravalvular leak. After tether tension is fixed to the apex, a final complete evaluation of the valve is performed to evaluate for position, stability, paravalvular leak, LVOT gradients, pulmonary veins, mitral valve inflow gradients, prosthetic valve gradients. You can see the pulmonary vein flow is no longer reversed. There is absence of any significant LVOT or flow tract gradients in transgastric views. You can see in transgastric views the valve is positioned appropriate, is stable, no significant paravalvular leak or no paravalvular leak is seen. After completion of the echo, the fluoro is performed at the end of the exam to confirm the placement. You can see a marker on the anterior cuff that should be placed anteriorly or on the right of the screen. This is a picture that shows a few members of our Southside and Abott team. Comments and questions appreciated.